Hello, my name is Megan Simmet,
And I'm Gabby Thayer.
and we did our project on Steppage Gait, which is just an improper gait pattern. For a little bit more of an introduction on Steppage Gait, it is also called drop foot, high steppage gait, and neuropathic gait. And it is characterized by a foot drop, high stepping, and low or limited dorsiflexion, which is caused by weakened muscles that are normally responsible for dorsiflexion, and these include the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus, and the peroneus tertius. Continuing the introduction, Steppage gait has three major causes, which include nerve injury, muscle disorders, and brain or spinal disorders. So for nerve injury, there can be peroneal neuropathy or sciatic nerve injuries, traumatic injuries, which are associated with car accidents, hip or knee replacement surgeries, fractures of the pelvis, the tibia, and the fibular head, which you can see off to the right, tight casts, diabetes, and alcohol intoxication. For muscle disorders, these include things like muscular dystrophy, Lou Gehrig's disease, and polio. And then for brain and spinal disorders, these include stroke, MS, cerebral palsy, and Charcot-Marie-Tooth disease. For a little bit of background on Steppage gait, usually Steppage gait issues are found in the heel strike and toe off portions of gait, which are also called the initial contact and initial swing phases. In a normal heel strike, the foot is in dorsiflexion and is preparing for gradual lowering before the stance phase. In Steppage gait heel strike, the heel is lowered to the ground after the toe, which can lead to a toe drag and an inability to clear the foot and potentially lead to falling. In normal toe off, the weight is on the forefoot and there's a lift of the foot off the floor. And in Steppage gait toe off, the weight is on the forefoot and there's an inability to bring the toe off the ground normally, which results in exaggerated hip and knee flexion.
Here is a video showing an example of Steppage gait. On the way back, you can really see the foot drop, and you can also see the exaggerated hip and knee flexion.
Next, we will discuss current problems in populations affected by Steppage gait. So some of those populations include people with uncontrolled diabetes, hereditary diseases, alcoholism, people who have had knee replacement surgery, and even those who have had a leg cast. Low-income populations have a higher percentage of these Steppage gait issues just because they deal more with diabetes and alcoholism.
With each of these populations that we found affected, we also found some current problems. So with those who have uncontrolled diabetes, we found that up to 50% of patients have diabetic peripheral neuropathy. So this could be the peroneal neuropathy that is characteristic of Steppage gait. A genetic condition, Charcot-Marie-Tooth syndrome, is a pretty rare condition, about 1 in 2,500, but there is no known cure, so it's really about treating the symptoms, which includes Steppage gait. For alcoholism, there was a study that showed that gait problems were still prevalent after 1 year of being sober, so this is really a long-lasting effect of alcoholism. In knee replacement surgery, there was 0.3 to 4% of patients who had a total knee arthroplasty found to have this Steppage gait afterwards. And even people who have tight casts, they can have the peroneal nerve damage that is characteristic of this Steppage gait. Next, I want to talk about the procedure for identification. So to identify this gait, there are some different things that you can go through. First would be a visible examination, where you would see the foot drop, the high stepping, and the exaggerated hip and knee flexion to compensate for that foot drop. In a physical examination, the person performing it would be looking for weakness in the anterior aspect of the foot or leg, really those anterior muscles that Megan mentioned earlier. And then a nerve study could be done, either an EMG or nerve conduction velocity, and this will determine the amount of nerve involvement or denervation, looking at that peroneal nerve and seeing how much damage has been done to that. There are 3 different corrective treatments that I'm going to be talking about. The first is physical therapy, and this is one that is done for just about anyone with Steppage gait, and it focuses on strengthening the anterior tibialis as well as those other muscles that we talked about earlier. And these exercises can include a towel stretch, toe to heel rocks, marble pickup, resistance band exercises, and a ball lift. If the peroneal nerve is no longer functional, the corrective treatment used is often surgery. So this would be a peroneal or tibial nerve transfer. And afterwards, this would require the physical therapy that we just discussed, but it is for those who have very extensive damage to their peroneal nerve. In a study, this shows one patient who had extensive peroneal nerve damage and could not do the dorsiflexion, but almost fully recovered their ability to dorsiflex their foot afterwards. So this is a relatively new procedure, but has been seen to be very effective. The last corrective treatment that we'll talk about is the orthosis, and this is for patients who have a peroneal nerve that is intact. So this could be an ankle foot orthosis, and the purpose of the brace is just to maintain the foot in the neutral position during toe-off phase. So you can see a couple examples of what these would look like, and here you can see that there has even been a study done looking at the different aspects of the orthosis to see how to make it the most efficient for patients.
Lastly, for our future research, we wanted to ask the question, in what way can surgeons prevent peroneal nerve damage during a total knee arthroplasty? We basically wanted to see how we could prevent steppage gait before it becomes an issue.
So to answer this question, we looked at a couple different variables that could be researched to answer this, including positioning of the knee, so looking at different positions to see which one would cause the least amount of pressure on the peroneal nerve, looking at movement throughout the surgery to see if there is a way to move the knee so that this peroneal nerve isn't compressed for that long amount of time, and looking at time to see how long it takes for that compression on the peroneal nerve to cause nerve damage, and also looking at the nerve function monitoring, so looking at if we can monitor the peroneal nerve and see when it is becoming damaged, and possibly implementing one of the other techniques such as positioning or movement throughout surgery.
Here are some of the resources we used for this presentation, and thank you for listening.